Welcome to today's MESUD Learning Community webinar. Today we'll be hearing from Dr. Alane O'Connor on buprenorphine during pregnancy and postpartum. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, the MESUD Learning Community acknowledges that we are all on the ancestral lands of the Wabanaki Confederacy. We have a responsibility to acknowledge our Indigenous connections and the histories past and present of Indigenous land dispossession. Neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with accreditation requirements and policies of the ACCME through a joint providership with the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. The opinions expressed by the speaker in this webinar are their own and do not represent the positions of the state of Maine or CCSME. Recording and live stream transmission of this webinar without consent is not permitted. We'll have a few minutes at the end of the presentation for questions and answers, so please hold all questions until that time, or you can place them in the chat. And now I'd like to give a quick introduction to our speaker today. Dr. Alane O'Connor is the Director of Perinatal Addiction Medicine at Maine Medical Center and is the medical advisor of the Maine Maternal Opioid Misuse Initiative. She also co-chairs Maine Opioid Response's Clinical Advisory Committee, which advises the Governor's Opioid Response Director on clinical and public policy issues. Dr. O'Connor has more than 15 years of experience in addiction medicine and in a variety of settings, including the design and implementation of extended release buprenorphine pilot at Somerset County Jail, rapid access to substance use treatment in emergency departments through Maine Medical Association's Project RISE, as well as extensive experience caring for pregnant patients with substance use disorders in both inpatient and outpatient settings. And with that, I'll hand it off to Dr. O'Connor for our presentation. Thank you all for being here today.
Hi, everybody. Yeah, great to see you all. I'm 27 people at 2 o'clock in the afternoon. I think that's an awesome turnout. So thank you for coming. Bethany's going to put up the slides. As she mentioned, I have a lot of experience caring for pregnant and postpartum people with substance use disorder, have been using buprenorphine since 2007, and hoping to just sort of talk through some of my sort of tips and tricks, lessons learned along the way, and sort of how I think about caring for this population, which I think we just need to acknowledge has become a lot more complex. I think the polysubstance use, the social determinants of health, the environments our patients find themselves in now are just much harder, much more severe, much more difficult. And so particularly in the world of fentanyl, things have really changed pretty dramatically. So I'm going to talk about sort of how I do this in clinical practice and really focusing mostly on buprenorphine. And hopefully there'll be lots of time to have conversation at the end. Next slide, please. So the learning objectives, we're going to talk about the different formulations of buprenorphine and the related use during pregnancy, including the extended release product, which is always the one that people ask me about these days. We're going to talk about strategies for initiating buprenorphine during pregnancy and kind of how I think about it when I'm caring for folks in clinical practice, and then review a few of the other issues that we see with folks with opiate use disorder in pregnancy, such as the substance exposed infant notification, breastfeeding implications, and concurrent hepatitis C. Next slide, please. So I like to start with kind of just acknowledging the uncertainty when you're working with pregnant patients with substance use disorder. I think, it can be overwhelming. I think sometimes folks present sort of in a state of almost they themselves are overwhelmed. So they're coming in thinking, their plan was never to get pregnant when they were using substances. And there's a lot of things going on. And, oh my God, what have I done in terms of damage having used during the first part before I knew I was pregnant? Sometimes patients have had unprotected sex for years and never become pregnant. So they sort of assume they couldn't. And so they discover they're pregnant, 5-6 months into their pregnancy because they're just not expecting that could be something that happens to them. So it can be overwhelming. I think, acknowledging that particularly when there's a lot of issues present, it can feel like, oh my gosh, what do I tackle first? But I think just recognizing that the most important thing when you meet a pregnant patient with a substance use disorder for the first time is having her come back again for the next visit. And really acknowledging that even if you're feeling overwhelmed and uncertain as you do this work, your patient is almost always more fearful than you are. And so just remembering that, just creating a safe environment where it's okay to talk and, non-stigmatizing language and just accepting, whatever's going on in their life and not having judgment under any circumstances. So the other thing that when you're caring for pregnant patients with substance use disorders, best practice is often unclear as pregnant patients are excluded from studies. This is a constant frustration for me. So because we really don't include them intentionally, and in fact, usually exclude them from studies, which I think is unfortunate because I think we would have better data if we were able to study pregnant patients. And I think as long as you consented pregnant patients to something like, hey, we don't really know, this is something that could be a problem or not, but allowing them to make that decision for themselves. I think so much of the work we do around pregnant people is really sort of protecting the fetus, which is important. But we sometimes actually forget that there's a mom that's part of the equation at all. And I think so I come at this from the lens that the pregnant person needs to be considered all the time. The literature is absolutely limited, usually to case reports, case series. Sometimes it's subject to recall bias. So people might not remember what they did during the first 3 months of pregnancy. They may not have known they were pregnant, as I already mentioned. So there may not be good data because of that. So it's all retrospective studies. Most of the research that I've done in my career has been retrospective because of that. So you're trying to sort of tease things out after the fact, as opposed to really trying to study it kind of more forward looking. You do have two patients, but that only goes so far. And I think it's really important to remember to always not marginalize mom. The fetus technically has no rights until birth. And, again, there's lots of layers of ethics attached to that. But it's so important because I think sometimes, for example, some other provider may not be willing to prescribe a medication during pregnancy because they're like, oh, not studied in the fetus or something like that, rather than sitting with the mom and doing really shared decision making. Oftentimes people just stop things sort of cold turkey, which is not very helpful. And so remembering that I always tell moms, we want your mood to be as stable as possible. We don't want you to stop all these medications because, you're going to have a much healthier, successful pregnancy and probably have fewer returns to use if your depression is well managed. So it's really having that conversation with patients. In most circumstances, doing nothing is the worst thing that you can do. So channel that when you're seeing patients as well. I see so much that people are like, well, if you don't know what to do, don't do anything and just, have them come back tomorrow. And it's like, no, you have to help them when they're sitting in front of you and, and do the best that you can with the information that you have in front of you. What I always say though, when the fetus is viable, run the plan in your head one more time. So if I'm seeing a patient and the, good example was not too long ago where I had sort of a 24, 25 weeker. So the fetus was viable. And, I'm thinking, okay, if I precipitate withdrawal and this woman goes into labor at home, what does that look like, right? So kind of running that equation in your head one more time, like, have I adequately sort of consented her to the risks of precipitated withdrawal? Have I tried one more time to see if she's willing to do supervised withdrawal or go inpatient or something like that? So just kind of running the plan one more time and make sure that your patient always knows the pros and cons of each approach. I really try to sort of, again, share decision making, giving the patient all the information that she needs, and then documenting well. I think that's always a good habit, but I think it's really important to say, hey, I counseled her to the risks of precipitated withdrawal. She understands this is what could happen, and just making sure that's all in the note. Next slide, please. So a bit about the landscape in Maine. Maine has historically had one of the highest rates of opioid-exposed pregnancies. So this has been true for years. So together with West Virginia and Vermont, we tended to have the highest rate. This is a study actually that I published that you'll find all these references in the reference list at the end, but this is a study looking more recently, so from 2016 to 2022. The prevalence of maternal OUD in Maine decreased from 35.3 to 18.8 deliveries per 1,000 deliveries, and it was about the same amount with the infants with neonatal abstinence syndrome or NOWS. So a pretty marked decline, almost cut in half, which is dramatic. There are other states that are seeing this as well, some not as significant of a decline. We actually still don't know why. We're doing some additional research to try to better understand where is that decline coming from. Because certainly we don't always want it to go down from the perspective of if a patient's on MOUD and in treatment, like that's certainly much better than using substances during pregnancy. So, and that technically would be an opioid exposed pregnancy. So it's always sort of this balancing factor. But we don't really know why. We're wondering, one question, is there better access to inpatient long-acting reversible contraceptives? So think it was in 2017, it became sort of unbundled. So historically, if you put in a LARC during a postpartum process, that was not covered sort of separately as a procedure by main care, and that became unbundled in 2017. So there does seem to be an increase in the use of long-acting reversible contraceptives, particularly the post-placental IUDs. So is that sort of contributing to a reduction in kind of the next unexpected pregnancy? Hard to say. I think the other question that I think about pretty much daily with my team in the clinic is, has another SUD replaced OUD? And we are really to the point where we're seeing, I often describe a third, a third, a third. So we have a third with opioid use disorder, a third with stimulant use disorder, and a third with alcohol use disorder. So are there other use disorders that are happening more frequently? And that would not be an opioid exposed pregnancy, for example. Next slide, please. So a little bit about opiate use disorder in general in pregnancy. I think really important to remember, pregnant patients have priority access to treatment. So that is on your side when you're caring for a pregnant patient. They usually can get priority access to treatment beds, to supervised withdrawal settings, to a lot of other things. So it's really important to remember that. And I always say to patients, if they're calling for a resource, like, make sure you say you're pregnant in the first couple sentences, because that helps kind of move people up the list, and that's important. It's a tremendous source of motivation. It's the joy of working with pregnant patients with substance use disorder, is, literally meeting a patient, incarcerated when she discovers she's pregnant, to now having her own apartment, raising her child, have her own job, going to school, just like the complete shift in her life. And it's just been remarkable and just a complete joy to be part of that. So they often have a tremendous source of motivation because they have that fetus growing inside them. But at the same time, they're usually like, oh my God, is DHS going to take my baby? So there's this constant sort of back and forth, which does make it challenging to care for folks, because you can understand why they might not be motivated to seek care if they're still using substances, or to tell you what's going on, because they're fearful that that will, make their DHS more likely to take their child. So there is this constant sort of back and forth. I think oftentimes you can see them sort of wrestling with it in their own minds. And it's true that many folks do not seek care because of this. I think they think maybe it's better if I don't get any care at all, so people don't know that I'm using substances. And that's really unfortunate. And I wish we could sort of get a better handle on that piece and really sort of prioritize folks who are actually engaged in treatment. Buprenorphine is first line in pregnancy, as is methadone, but this is a buprenorphine lecture. Monotherapy or combination therapy with naloxone can be used. There's a nice position statement that the Clinical Advisory Committee put together on the topic, and that's linked right here. Historically, we used monotherapy or Subutex. That wasn't because we knew of any problems with Suboxone or the combination product, but just because, the thought process was it's better to expose a patient to one medication, not two. We do know that the mono product is probably more misusable, divertible. I certainly had situations with a pregnant patient where the partner was actually taking the mono product and the pregnant patient was taking the combo product because the partner was misusing it. So it creates kind of sometimes challenges within relationships as well. Used to be, monotherapy is absolutely covered in pregnancy. So, and that's actually going a lot simpler now. Probably 3-4 years ago, I would write pregnant in capital letters on the prescription, and that may or may not get it approved. Now, pretty consistently, if you write pregnant on the prescription, for mono products, there isn't like a delay or anything like that. But I used to tell people, like, look, the mono product, happy to put you on it, happy to make this your choice during pregnancy, but it may be related to more sort of challenges at the pharmacy. So combination therapy, completely fine. Oftentimes simpler, like particularly if they're stable, because people don't really do well always if they're sort of going back and forth between different product. So if they really like the film and the mono product doesn't come in the film, then that's a really great reason to keep them on the combo product. Infants born exposed to any form of MOUD, or I should say methadone or buprenorphine, are at risk of withdrawal syndrome. So you probably hear NOWS a little bit more commonly now, which is neonatal opioid withdrawal syndrome. You might hear NAS, neonatal abstinence syndrome. I think both are probably used. It's really important. Honestly, in the first visit, I start talking about expected 5-day hospital stay for eat, sleep, console monitoring. So that's the way in which we monitor for NOWS, which is a much more patient-friendly process than the old sort of scoring tool that was used, which patients got very attached to. If the score went up or down, it was just very difficult for them. And Eat, Sleep, Console is much more patient involved. So they're part of the process of making decisions. Is the baby eating okay, sleeping okay, consolable? It's just a much more patient-friendly process. We talk about the substance exposed infant notification, which is on a later slide, so I'll talk about it then. I think it's really important to remember that there might be partners, other people in the home that also need treatment. Really unlikely for people to be able to stay on track with their recovery if they're directly surrounded by people who are using substances. So important to ask that question, connect people with resources. Peer support is particularly important. So I always say there is no, people with substance use disorder are historically stigmatized, shamed, marginalized. And then within that population, the pregnant patients are like especially shamed, especially stigmatized, because so often I gave a lecture this morning and people are like, how do people use drugs when they're pregnant? I'm like, because they don't want to be doing this. Nobody ever said they came in and, oh, I really want to be using substances when I'm pregnant, right? They have a substance use disorder. They are unable to stop using without, medication support and a whole bunch of other things. And so there's a lot of judgment and shame put on this population. So our peers are probably the most important part of our program, hands down, and really can walk a patient through that substance exposed infant notification process. There's no one who understands them like somebody who's walked in their shoes. And I think this is particularly true within the pregnant population. Next slide, please. All right, so starting buprenorphine in pregnancy, this is not easy. Let's just acknowledge that right up front. In the fentanyl era, we understand that the norfentanyl stays in the system for 50 hours or more, and so you see, the metabolite interacts with the buprenorphine when you start it, even though they may feel like they're in withdrawal because that sort of primary substance has been metabolized down. So it's very difficult to start. The old days of when it was heroin, I could just talk to people and say, this is, we used to do in-office initiations 15, 20 years ago. And I could very easily describe, like, this is the clinical picture. I want you to come in, a little bit sick, not too sick, a little nauseous, not having diarrhea. And people could very clearly say, oh, that's, however many hours. And they could time that perfectly. And it went beautifully. That no longer happens at all in the fentanyl era. So it's the case that people are feeling sick before all that metabolite is out of their system. They want to start something. They are terribly fearful of making themselves really sick because if they precipitated withdrawal before, they know it feels terrible. And so they don't want to do that again, understandably. So you definitely need to talk to patients about that risk of precipitated withdrawal before you begin buprenorphine. It's important to consent patients to that risk, but it should not limit access to treatment. I sort of feel like I should say that again. Like, it should not limit access to treatment. If you have a pregnant patient, you want to start buprenorphine, she understands the risk of precipitated withdrawal, I really feel like it's your obligation to help her, right? It's not like, go somewhere else, someone else can figure this out. It's like, she's in front of you, you have that moment to act, do it. And so I think that's really important. There's also a new-ish study that showed over 5.5 years, there was 301 pregnant patients with opioid use disorder who ended up in jails and prisons in a different state. Were fully detoxified during pregnancy with no adverse fetal outcomes related to detoxification. So to be clear, I am not advocating for detoxing people off these medications completely. I'm merely noting that historically we felt like, oh my God, if the mom experiences withdrawal, the baby's for sure going to have all kinds of complications. You're going to have a miscarriage, all these other things. And I think as we understand more, the fetus is actually really resilient. It's not without potential complications, but it's not this hugely fearful thing that we once thought it was. Your best option, so if I'm seeing with a patient, sitting with a pregnant patient, and she's on, several grams of fentanyl a day, I think the best option really is a supervised withdrawal setting. If you're able, again, this is like meeting patients where they're at. So this is usually what we start talking about. Hey, interested in Milestone in Portland, New Horizons in Bangor. There's other ones. These are just the ones I use most frequently. And again, priority access to admission. So it's often the case that we can call in the office that day and there's a bed the next day, or even sometimes that same day. And so patients can really get in there. What's nice is that, they can be transitioned to MOUD in that setting, but it's a comfortable setting, right? So if you have somebody who's unsheltered, unhoused, it's a place where they can have a warm bed to sleep in. They can have the other medications that will make them feel more comfortable. They have food, all the things that are going to make this a more successful transition. So that's usually where I start. Patients often want to do residential treatment. So they may come in and say, I want to go to Crossroads. That's where I've had good luck there before. And it's a wonderful program. But really, they oftentimes people forget that they actually need to be on the MOUD first. Like a place like a residential treatment program can't necessarily manage the initiation onto MOUD, but they will take people who are on MOUD. So typically, there does need to be sort of a first stop. That could be the inpatient unit, could be a supervised withdrawal setting to get them into treatment before they're eligible for a place like Crossroads or similar. And the reason I really want to mention that is that like oftentimes these places have like one bed once, right? So you want to use that bed to the highest, take advantage of it when that patient's ready to go. Sometimes I do see pregnant patients sent there when they're not on MOUD and then they leave after 3 days, right? Because they're terribly sick because they're an opiate withdrawal. So that makes perfect sense. But that's unfortunate because then there maybe is like a 6-month rule or something before they can go back again. So just making sure you're setting them up for success. Inpatient admission can be ideal, especially if the fetus is viable, patient hasn't received any prenatal care. So I often start with that, depending on how pregnant the patient is. So if 6 or more months pregnant for sure, if they've had no prenatal care, I'm like, how about we just go to the inpatient unit? We can make you comfortable there. We can get you started on MOUD, whichever one you would like. We can do some monitoring. We can get you that ultrasound that you need, and all that stuff can happen so much quicker if they're on the inpatient unit. All those things can be ordered at once. All the labs can be done. And again, we'll talk about that. What's nice at Maine Medical Center is actually we have an OB-ED that's separate from our regular ED, so people can go right upstairs to the OB-ED, and they don't have to go through the regular ED if they're more than 17 weeks pregnant. So it's a more pleasant experience from you get right into a bed on an OB floor, and you're not sort of dealing with being in the waiting room for hours and things like that. So that is helpful for us. Outpatient initiation is not easy. Let me just say that clearly. If you think I have success at this all the time with pregnant patients, that is completely untrue. It's not easy, but it's ultimately your patient's choice. So if I'm sitting with a patient, no matter how pregnant she is, and she's like, absolutely not, I'm not going to a supervised withdrawal setting. Absolutely not. I'm going, no way I'm going to inpatient. I would like to go home and do this myself. Okay, right? We have that conversation. We talk about the risks. If if your fetus is not being monitored, if you haven't had any prenatal care, do we even know that the fetus is still alive? All those things are going on. So we don't know, but ultimately it's her choice. And I really try, even in really complicated cases, to let people make that choice themselves. As long as they're consented appropriately to potential complications, I really want them to have a way to get an on-call provider all the time if they can, and then document defensively. Again, you've consented patients to the risk of what you're doing, particularly in the cases with complicated pregnancies. And again, this is not, I've had patients come in who are bleeding, who, using copious amounts of drugs. I've been like, please go inpatient. And, they won't do it. And ultimately, I give them whatever access they're willing to do in that moment, because the most risky thing for me to do is to be like, you know what, just go keep using fentanyl, right? That is always going to be the most dangerous thing. And if a patient doesn't want to do what you think is the best choice, you just got to live in a space where you're meeting them where they're at. Next slide, please. So low dose initiation in pregnancy. So this is called microdosing. People have probably heard about that. Again, it's not impossible, but not simple. This is hard, particularly when people are using fentanyl daily, because ultimately you're having people continue on their full agonist while they're microdosing themselves up. So again, inpatient is far simpler to do this because they can use other sort of longer acting opioids when they're doing this. But it leads to a lengthy hospital stay. So oftentimes if we're going to microdose somebody or low dose initiate on the inpatient unit, they may be there for 8 days, 10 days. And, that's not something that a lot of people want to sign on to all the time. If you can even get a bed for that long, sometimes you have to negotiate that part of things. But it can be difficult and patients don't often want to stay that long. Some people are using Belbuca or Butrian. So those are the non-OUD versions of buprenorphine. Belbuca is a buccal film for pain. Butrian's as a patch, also for pain. Some people are using that kind of as the initial low dose buprenorphine rather than what you see here on day one, which is 0.5 milligrams once. Some people are using those to kind of start the process. It can be done easier in the hospital setting than on the outpatient side. Some people now, and I've seen this done as well, are encouraging actually to go via the methadone clinic. So sort of if they're using fentanyl daily, they go and get started on methadone because that's simpler because it's also a full agonist. Then if they really want to be on buprenorphine, you can take them from methadone to buprenorphine because you better understand how how methadone works. So there's a more clear, like these microdosing protocols actually work pretty well if you're going from methadone to buprenorphine, far less so from fentanyl. But again, it's the patient's right to try. And people, I think the most important thing I see where patients really usually struggle is that they're sort of microdosing their way up or low dosing their way up. And then they're like, oh, this is going great. I should just take twice the amount. And that's when they precipitate withdrawal. So it's really important that they kind of stick to this plan. It is hard to tell them to continue using fentanyl at home, right? I mean, that's what you're doing ultimately. That doesn't feel good. Again, this is why it's a lot better to do it in another setting. But again, patients often don't want to do that. And so I try to meet them where they're at. Next slide, please. High dose initiation in pregnancy. So this one might be called macrodosing. I reviewed the literature. I haven't done this myself. I've done a lot of like high dose initiation in correctional settings or part of it there. I have not seen this done in pregnant patient. I've not seen it reported in the literature. I don't think there's anybody saying, oh, you should do this. And so this is kind of a standard. This comes from there's a citation there. I think it's the Herring article. But this is kind of your standard high dose initiation policy or procedure. So I think the message that I have here is that like it's probably not recommended to do high dose initiation. So that could be like 32 milligrams in the first day that you're sort of pushing. So you probably precipitate withdrawal, but you kind of just push above it over time. And it can work very effectively. Again, I haven't seen it reported as kind of a recommended approach in pregnancy, but I do want to say that if you precipitate withdrawal, and I've seen this happen more times than I can count, then people stop. They're like, oh, I precipitated withdrawal. Why don't you go home and we'll start again the next day? Like, no, right? That's not a good plan, because when she leaves, because she feels terrible, because she's had precipitated withdrawal, she's going to go use fentanyl, right? Because she's going to want to feel better. So like if you precipitate withdrawal, keep going, push through it, get her on that dose that she needs as much as you can. So again, I wouldn't necessarily recommend the high dose, but if you do precipitate withdrawal, push through it and give her what she needs to feel comfortable. Returning to fentanyl is almost certainly the riskiest choice. And again, we're having these conversations as things are going. And I think that's the part where, when you talk about at-home initiations and things like that, really making sure the patient understands these are the risks. This is why we want you to do it on the inpatient unit, so we can monitor the baby, monitor the fetus, make sure things are okay, do this, get you the medications that will make you feel more comfortable. But again, it's her right to do it where she wishes. Next slide, please. Extended release buprenorphine. So this is probably one of the most common questions I get. Do I use this during pregnancy? Yes, I do. It's, again, one of these things that's frustratingly not studied, right? Because we don't study pregnant people. So we're sort of going, I talk to patients about the pros and cons to extended release buprenorphine. So those of you who are not familiar, there is a weekly version now, and there's a monthly version, which has been, they've had the monthly version for quite a while. The monthly version of both the two products that are available, Sublocade and Brixadi, have this NMP as a stabilizer in it. So it keeps the medication kind of stable in the syringe, and in relatively high doses or significant exposure that has been associated with fetal complications, sort of particularly in the first trimester. But again, it's one of those things that, as with typical things, it's when they've exposed rats or what have you to like 30 times the amount or something like that, where you see problems. There has been a few case reports that I've read from like other countries, because it's used in the textile manufacturing in other countries, where people who are exposed to huge amounts of that while they were working and pregnant did have some fetal complications. So we have that conversation. You could just use the weekly shot and avoid that problem altogether. I have yet to have a pregnant patient say, please give me a weekly injection. Like, right, who wants to come back every week and get a weekly injection? I've literally never had a pregnant patient say, I would like to go that route. So we have this conversation, we talk about it, we don't really know, but I'm part of a variety of different listservs across the country where these conversations are had. There's some places where people are using this almost first line. I wouldn't say I'm there yet, but I am using it, and people are not reporting challenges. So there's emerging evidence, as I said, sort of case reports, case studies, because this is how this works in this line of work. So it does not identify any specific adverse outcomes. There doesn't actually seem to be a difference in outcomes in the weekly versus the monthly dosing option. So they've studied that a little bit in populations that are willing to get the weekly shot. We think actually that the study drug concentration may improve treatment adherence. I think that's absolutely true. I use this a lot in a correctional setting. And it definitely seems to improve treatment adherence, particularly post-release, pregnant patients' health, contributing to the overall well-being. So we're actually seeing a more milder neonatal withdrawal symptom in folks who are in the babies born to folks who are on the extended release product. So that's kind of an interesting emerging finding. So, and it makes sense, right? If you've got these kind of steady state blood levels that the baby's exposed to as well, there isn't kind of the daily ups and downs that you sometimes see with the daily product. They do require the usual 5-day monitoring. So I've literally had 3 pediatricians ask me, because I guess the confusion around where this depot medication sits, but it sits in the mother's subcutaneous tissue. So sometimes people think, oh, the mom's on an extended release product, I have to monitor the baby for 30 days. I don't know why that happens, but like when the umbilical cord is cut, it's the same as it would be when people were on the daily medication. But there's just confusion, I think, because people don't really know what this is. So I've seen that literally 3 different times. So I tell people, like when I'm teaching the residents, which I was doing yesterday, like, hey, just remember, you don't have to keep the baby for 30 days just because it's slowly dissolving in mom's system. It's not any different for her, for the baby. It might be a suitable option during pregnancy. Larger studies would be super helpful. Again, I use it. I think the most important messaging is to make sure that if you have a person of childbearing age and they're not on contraception, you should be talking to them about the risk of use during pregnancy, because if there is a risk, it's probably that first trimester. And so it's important to make sure that they're aware that if they're on this medication and they become pregnant, just that you've had that conversation before they become pregnant. And many patients are, choosing to stay on it during pregnancy. The Brixadi, and again, I'm not endorsing any medication, just merely discussing the differences, is a little bit easier to administer during pregnancy because you can put it in more sites. Although Sublocade recently changed and says you can do it in other sites as well. So historically, Brixadi, you could do it in the buttocks, on the arm. There's one other place which is escaping. I think the thigh. But Sublocade historically you've had to put in the abdomen, which has been a little uncomfortable to put it in when people are pregnant. But you can kind of go more lateral as needed, and that's worked pretty well for us. Next slide, please. So more about buprenorphine in pregnancy. Patients often require a dose increase during pregnancy due to the physiologic changes of pregnancy. So that is a normal phenomenon, not true for all patients. So it's not everybody who will have that experience. It's really important. So I was literally talking about this with a patient yesterday. It needs to be normalized. So explaining, particularly for patients who that's their first pregnancy, that as your body changes, as your blood volume increases, as your metabolism changes, that may change how your medication is metabolized in your system. You may not notice any differences, but I always tell patients, you might feel like the medication's not working as well as it did before. You feel like you want to take your next dose earlier than you do typically. You start feeling like, the creepy crawlies or muscle aches or cravings, or you start having drug dreams or something that makes it feel like the medication is not working as well. So just to sort of give them that information, because historically people have not wanted to say something to me if I didn't give them that information, because they feel like they're doing something wrong. Like, oh, it must be my fault that I'm feeling these symptoms, or I must be doing something wrong and not doing this correctly. So just normalizing it, saying, hey, you might experience this, you might not. If you do, it's not because you're doing anything wrong. It's because that's the way your body changes during pregnancy. Just let me know and we'll adjust the dose as needed. This generally occurs in the second trimester, not necessarily. I used to think it was sort of exclusively second trimester. Now I don't, it could be really any time, in part, I think sometimes because people are starting on things later in pregnancy. So finding that sort of ideal dose can be sort of a bit of a moving target. So it can happen kind of anytime. I do have a lot of patients who report that, like, when they notice it when they feel like their belly pops. So they're like, I noticed my belly pop and suddenly my Suboxone wasn't working as well. So there seems to be some correlation just anecdotally in my clinical practice, but that again, it could happen anytime. Those changes are typically pretty subtle. So if you have somebody on 16 milligrams of buprenorphine, you might get them up to 20. It's not like doubling the dose or anything like that. It can be harder to manage with the extended release product for sure, because extended release product is a bit of a one size fits all. There's 2 doses of Sublocade, 3 basically of the monthly version of Brixadi. So I will sometimes add on sublingual buprenorphine for a period of time. Sometimes I'll adjust the dose of the Sublocade. I do something differently, usually postpartum, try to figure out like back to sort of a steady state dose. Do they need to go from the 100 back up to the 300? But I might sort of tinker with things, in part because sometimes it's a little hard to tell. Like if people are not having any cravings or drug dreams or any kind of the psychological symptoms, sometimes, when people are pregnant, like they don't feel great, right? They have muscle aches. They have things that could feel like it could be withdrawal. So if you add on 2 milligrams of buprenorphine and there's absolutely no change in the symptoms, then it's probably not the opioid that's the issue. It might be some other thing that's going on, or it might just be that she's 34 weeks pregnant and it's 80 degrees outside and that's uncomfortable. So it's good to just have those conversations. And definitely, so patients do metabolize quicker. Sometimes I do BID or TID dosing. So I don't typically do more than that though, because people who doesn't work well when people take like pieces of their, I took, a piece of my film 8 times a day or whatever, because I think they have trouble keeping track of what they've taken. So I really try to say, okay, you could go to TID dosing. Like if you're on 24 milligrams, you could do 8, 8, 8. That's fine with me. I try not to do any more than that because I think people have trouble keeping track of their prescriptions. And certainly don't like abruptly reduce the dose. I do see this happen sometimes. Like people are on 24 when they deliver, and then it's like, let's cut them to 16 the day they deliver. And I'm like, let's not. But that's not very friendly. So sometimes people go back, sometimes they don't, but it's certainly not something that should be done in the delivery hospitalization. The other thing really important to counsel patients about is the maternal dose of buprenorphine is not correlated to the degree of withdrawal. Hugely common misunderstanding, and it makes perfect sense that if someone was on 300 milligrams of methadone, for example, their baby would have 3 times more withdrawal than somebody who's on 100. Like you think that would make perfect sense. That's what patients assume, but there is no relationship. So the important piece about communicating that is patients will often keep themselves arbitrarily low because they're like worried about their baby's withdrawal. And so they'll be like, staying on 100 milligrams instead of going up to 140 on methadone or something like that, because they just don't want to increase the risk of withdrawal. And so they're uncomfortable. They may be having returns to use and things like that. So it's really important to, again, tell folks the best dose for you is the dose in which you feel comfortable. And don't think that the withdrawal pieces for the infant is linked to that. Next slide, please. Hepatitis C during pregnancy, super duper common. It's about half my patients have hepatitis C. Important to screen everybody. That's the standard of care now, but particularly important to screen folks with substance use disorder, even if they've been treated before, because if they've had an additional return to use with needles, they certainly could get exposed again. Patients are always very worried that their infant is going to be, get hepatitis C if they have it. So it's important to make sure that the infant provider knows. And, I was talking to a patient yesterday again about this. And, sometimes the medical records don't talk. So it's just really important. I try to educate the moms about like, hey, this is what needs to happen as well. So in case that information doesn't get connected to the infant's chart. There's a couple different ways you can do this. If you're screening for the antibody, you typically wait till 18 months of life for the kiddo, in part because earlier than that, the kiddo might still have some of mom's antibodies. You can do it much earlier if you use the RNA test. I don't know, whether there's a value to that psychologically or not for patients. And so again, I just sort of tell people and to have them talk to their pediatrician or pediatric provider. But it is an option. I don't think last time I checked, you couldn't treat younger than 3. I don't know if that's changed, but it certainly probably isn't, 6 months of age. So, but vertical transmission rate is low. It's only about 5 to 7%. And the method of delivery does not change. That's a common question people say. Well, do I have to have a C-section because I have hepatitis C? And no, you don't. Treatment of maternal HCV, as far as I know, last time I checked, is still not recommended during pregnancy or breastfeeding, but we try to treat as quickly as possible thereafter. So the patient I was starting yesterday was, I think, about 3 weeks postpartum. She's not breastfeeding. Relatively easy to treat uncomplicated HCV in the outpatient setting. So we've developed a little algorithm through the Main Mom program. Super easy to do. Just it has a prior authorization through Main Care. Have to do some labs. The one that I think is always really important to do is just that pregnancy test again, if somebody is, a person of childbearing age. But it's really easy to treat. It's like, 8 weeks of medication. It's almost 100% effective. Nothing's 100%, but very, very effective. And patients feel good when they're taking the medication. It's not something that causes a ton of side effects. So it's really important to do. And also to counsel people that they could get it again if they go back to using IV drugs. Next slide, please. Delivery planning, really important. So, we're talking again about the 5-day hospital stay. We're talking about the substance infant notification, also talking about pain management. That's one of the most common questions I get. Are they going to take care of my pain? Are they going to, quote unquote, treat me like an addict if I ask for pain medication? I really encourage people to, be up front when they have pain, speak up. We want to treat it before it gets, out of control. And really, the greatest risk of a return to use is untreated pain. So really advocating for themselves. And we've done a ton of education on the inpatient unit. And I will say this is, there's very accepting, understanding of people who are on MOUD and really working with folks in a very effective way. So you do continue the buprenorphine. It does not provide adequate pain relief. There's been a lot of confusion about that. Short-acting opioids work really well, which you can use. It does require more frequent dosing. And maximizing the non-opioid options is always a good idea. Epidurals can be ideal, but they do contain fentanyl, not always, but a lot of the time. The vast majority of them, at least that I see done, do contain fentanyl. That makes things complicated because of it would be easier if things were still heroin, right, from the poppy plant, but it's now fentanyl. I've had lots of conversations with OB anesthesia, and there is not a alternative opioid that can be used as successfully. So they don't want to use a different medication like morphine or something because it's not as effective, not as successful. And you can't sort of treat one population differently than another, particularly if you can't really identify that population initially. So what I tell patients is it's super helpful. Again, having this conversation with the patient yesterday, I saw all these people, different people, but all of these issues yesterday. So I said, when you go to the OB floor to deliver your baby, as soon as you get there, I want to leave a drug screen. I want to leave urine in a cup. I don't want you to give me any medications until I have that drug screen. And that's them sort of self-advocating. So that takes the whole question of whether the fentanyl in the epidural, which absolutely can cause mom to be positive and baby to be positive in that narrow window of time post-delivery. So that takes the whole question of whether she had a return to use before she came to the hospital right off the table. So I literally was counseling a patient who's 39 weeks pregnant. She's like, yes, I'm going to ask for a cup the second I get there so I can leave a urine. So that takes that whole question right off because it's like the very best random ever, right? Because nobody plans their vaginal deliveries, or I don't know how they plan their vaginal deliveries. So it's always random. So it's a really good random source of information. So again, be sure to talk to your patients about that because that's so frustrating when that gets missed and that the question of like, well, did they use, I don't know. Like, it's frustrating when that gets missed. Next slide, please. So OCFS notification. So it's half of all child removals in Maine do involve substance use. This is an issue that I lecture about all the time in terms of the risk to families of ongoing substance use, particularly if there's little kiddos like babies in the home. This is the statute as it's written right now. So basically it requires the healthcare provider to report any infant affected by substance use or that has withdrawal symptoms that require medical monitoring or care beyond standard newborn care. That is legal or illegal drugs. I'm sort of picking out the bold pieces here, or fetal alcohol spectrum disorder. So that absolutely does include people that are on MOUD, and it could just be MOUD. In other words, 10 years of stability, no returns to use, that person still does get reported. There's lots of conversation about how this should be written, could be written. There was actually a bill on the floor in early February, but that was continued to the next session. I think part of it is trying to figure out like what is the ideal policy. And I was on a call earlier today talking about that. Like, what should that look like? Who should be reported? Is it consistent with federal law? Like making sure that it's all, sort of consistently applied. That's the part I think that's hard, is that you don't always see it consistently applied, certainly across hospital systems. So this is the number to report. There's online reporting also available. I always tell residents, if you're in doubt, report, in terms of like when you're working with families. If you're thinking, should I report this case? You probably should, because it's probably more complicated than even you think it is when you're seeing them in the office. Plan of safe care is compiled. So that's really just kind of a document of all the different things that the parents have done to sort of keep themselves on track. What is their plan of a safe environment to take that kiddo home to? And that I think of it as like sort of a positive reinforcement of all the things that they've done. Next slide, please. Breastfeeding, another common question. So buprenorphine, absolutely compatible with breastfeeding. Infant serum levels are typically quite low. Absorption is actually limited through the GI tract. So people ask, is the baby going to get all the same amount in the breast milk that they've had when they were, as a fetus, developing fetus? And it's much, much lower. So abrupt discontinuation is okay. This is a common question. If like a child is removed by OCFS, like if they're not able to kind of continue breastfeeding for whatever reason, is that going to cause a problem? No, it's not, because the levels are low. It probably does actually reduce NOWs, but it seems to be the act of breastfeeding, not necessarily ongoing exposure to the medication. So it's the act of breastfeeding, the sort of close contact, skin to skin, soothing and reassuring. There's a tremendous amount of conversation about the timing of most recent substance use. This is something I'm having dialogue with folks across the country almost every day. This is a paper that's still fairly recent, and one of the authors and I go back and forth on this topic a lot. But actually, the literature suggests that only SUD at time of delivery is actually a predictor of postpartum return to use. So historically, there were sort of these other policies that was like, if you had a return to use 30 days before delivery, that person shouldn't breastfeed for some period of time. They've done a lot of sort of literature reviews looking at it, and it does seem to be that only that if people present to the hospital having had illicit drugs in their systems, is that sort of a predictor of postpartum return to use. So if that happens, we certainly encourage people to initiate, pumping, and we want obviously the infant not to be exposed to any illicit drugs, but you can certainly initiate the process so that when those illicit drugs do pass from the system, that the baby can be breastfed. Active drug use, I think, isn't contraindication, as is HIV. That's a really nice document there that's linked. Hepatitis C is okay to breastfeed. Really common for folks to think they can't breastfeed. As long as the nipples are not cracked or bleeding, it's fine. I think this could be a lecture on its own, but just acknowledging that the history of trauma may impact interest in breastfeeding, and just the amount of trauma this population has typically experienced. And so again, I try to just meet people where they're at. We talk about breastfeeding. Is it something that you're interested in? Is it not? What are your questions? What are your concerns? But it's totally her choice. And I don't push her on it if she's like, this is not what I want to do. Or some people can't actually breastfeed, but they can pump, give their baby breast milk in a bottle. I support whatever she wants to do, whatever's comfortable. If she doesn't want to do anything at all, that's fine too. And if they want to share why, that's fine, but they don't have to. And it's her choice, what she wants to do. I think so often this population doesn't feel empowered at all. So I try to make them feel empowered with every decision that's made, that this is your choice and your decision about what you want to do. Next slide, please. So overdose, one of the leading causes of death of pregnant people in Maine. That risk sort of increases, particularly in the late postpartum period, particularly if the mom has lost custody. And naloxone is key. Prescribe it often, give it to people, tell people how to use it, affected others. Everybody should have naloxone, I think, just as a sort of being a good citizen in society. We should all have naloxone so that if we ever need it, it's there. Next slide, please. So briefly, Maine Mom, just in case folks are wondering, what is Maine Mom? It's a Maine Care covered program for pregnant and postpartum people or post-pregnancy people for up to 1 year. And they do have to have OUD. That's a part of the federal grant that created the MOM program. So what's nice about post-pregnancy is it could be somebody who has a termination. It could be somebody who has a miscarriage. And so they're all eligible to enroll in MOM. What do we do? It's comprehensive care, including MOUD, counseling, peer support, obstetrical care. So some of it's all delivered in one setting in terms of under the same roof, literally. Sometimes it's under two different roofs, but well connected with, in my program now, because we've moved to have more space, our nurse care coordinator and our clinical team assistant go back and forth between the two sites. So there's common faces, common experience, but the addiction care is actually provided in a slightly different setting. Patients don't have to be on MOUD, nor does mom have to be the provider. So we can see patients at Maine Mom who are on methadone, and that's perfectly fine. Or if you have a patient that has not on MOUD for whatever reason, they can also come to Mom as long as they have an OUD. Comprehensive care coordination. So the team just does everything under the sun: transportation, safe storage of medication. We attend a lot of family team meetings with OCFS, coordinate with PCPs, make referral to specialists, getting parenting classes, really whatever that patient needs. And oftentimes we use the reunification plan, particularly if that child has been removed. Some, but not all Maine Mom programs treat all SUDs. There is an ongoing effort to expand Maine Mom to include all SUDs, like with the opioid health home models, but we're not there yet. But for us, we treat your SUD no matter what it is. Not everybody is able to do that because of the way their system is set up, but we do in Portland. Next slide, please. So I just want to talk briefly about Project Lifeline, and I won't talk too much because I want to make sure we have some time for questions, but this is a really wonderful partnership with the Portland Fire Department, which I absolutely love. So we go out together a couple times a month and see my unsheltered, unhoused patients this is one of my patients who I'm listening to her lungs, who lives in a tent. We provide care on site directly. And what's really helpful is these folks are all community paramedics, and there's actually, I think that was recently approved, so they're going to be able to bill for community paramedicine, but they are just an incredible resource. If I have a patient which happens all the time, right? You have somebody who comes in who has a stimulant use disorder, blood pressure is kind of off the chart for a whole host of different reasons, largely from the stimulants. And I'm like, oh, can you please get me a blood pressure the next day? This is a team that can go out and get that for me and provide that information real time. Or if we're trying to reach a patient that doesn't have a phone and we're trying to give information, that team can go out and find that person. They all sign releases to participate in this. So this is not, sharing information that shouldn't be shared. But it's a beautiful collaboration. They also refer patients in all the time. So I've had them at the homeless shelters before, like walking by someone who hears them say they're pregnant, and they'll just literally say, hey, have you heard of Maine Mom? So it's a really nice partnership that we have. It's a great joy to be able to practice with these folks. And I think nice way for them to kind of learn more about substance use disorder. I do a lot of teaching in the community, even if they're not necessarily my patient. So many of them didn't have any idea what extended release buprenorphine was before we started working together. So that gives them the opportunity to be like, hey, there's this program down the street if you ever want this. And, and they can use that information as they see other people in the community. So I think that's the last slide. 2:52. We got a couple minutes for questions, and there's a ton of resources there. If anybody has any questions after the fact, reach out. Happy to talk to folks. And up to 36 now at 2:00 in the afternoon. I love it. Thank you for coming, everybody.
Thank you so much, Alane. Yeah, any questions can be placed in the chat, and thank you, Kathy, for modeling. You can raise your hand and unmute. So, Kathy, you want to start with our first question?
Sure. Dr. O'Connor, I was just wondering, I know reporting is always an uncomfortable thing for folks, and you mentioned that oftentimes people don't want to come for treatment when pregnant because they're afraid that the child would be taken away. So I was just curious if you are required to report if you think there's substance use or the patient's on mood, you said. How do you have that conversation with the patient? Do you tell them that, you are required to report? And then how do you maintain that therapeutic relationship where they want to continue to come and, get treatment?
Yeah, no, great question. So, my interpretation, so there's sort of two separate questions. Like there's a substance exposed infant notification, which is separate from sort of my obligation as a mandated reporter, which is, to report a child, whatever the age that child is, that's at risk of abuse or neglect. And, I know from clinical practice that substance use disorder is a major contributor to abuse and neglect, more often neglect probably than abuse. But so I'm always thinking about that. And, I'm also aware of children that have died as a result of substance use disorder in their family's household. So I understand the risk is real. We as a team talk about it a lot. Like, how are we feeling about this? Where are we? How are we feeling about the safety of the children in the home? Depending on where the substance use is happening, things like that. I, for better or worse, am a hopelessly direct person. Anyone who knows me on this call knows that that's true. And that's actually served me quite well when it comes to this. Like we had a case not too long ago that we had to report. We sat her down, said, we're reporting. We had talked to her about the possibility of reporting because we were concerned about the safety and well-being of her other children in the home. She was pregnant. We said, we're concerned. And if these things happen, we're probably going to have to report. Those things happened. We did report. We were totally transparent about that. And, she didn't love us. Like nobody ever goes, thank you for reporting me. Typically, I mean, occasionally that happens, but rarely. But most often, people understand and respect that that's my job. And it's like, I don't get any great pleasure out of doing it. It's what I have to do. I want to keep taking care of you. I want your children to be safe, as I know you want your children to be safe. And oftentimes, actually, when you report during the pregnancy, if there's stuff that you're really concerned about, actually, this particular patient, it worked out great because I think it heard it in a different way. Like, I really got to stop. I got to change my phone number. I got to not be using drugs. I got to get this on track. And now she has like 8 weeks of not using any substances. And she's grateful that we reported them because she was going to be reported at delivery. But now she has this 8-week window of time where she has been able to say like, hey, I don't have any substances in my system. So it doesn't work perfectly all the time. I have to live in a space where I feel like I'm, being a responsible provider. And so I land in whatever space that is. And if I feel like I need to report, I do it. Patients don't fire me or never come back that much, honestly. I mean, I think because I'm very upfront about it and I'm very prophylactic, like if I'm headed down that road, that they're aware of it. And so I typically don't report if I can get away with it the first time, because that's not going to develop a good relationship. But when people know me over a period of time, it works okay. Long
Thank you
one.
so much for your question. While we're waiting for other questions, I also want to direct everyone to links in the chat. The link for the survey for today is in the chat. Also, Dr. O'Connor is going to be presenting on Project Lifeline at our conference coming up in May. So if you would like to join us in person at Sabasco Harbor Resort in Pittsburgh or virtually on your computer, you can do so at the link right there.
Yes, and I'm bringing some of my fire department paramedics with me, so it will be truly a collaborative presentation, which is they're an absolute joy to work with.
We're very excited. Any other questions?
I don't think I put my email on the slides. I always try to do that, but I forget like literally every time. So I'm happy to put my email in the chat if something comes up afterward or you don't want to ask in the group. But again, I super appreciate everybody coming at this hour of the day. So let me put my email in the chat. I'm happy to answer any questions. Oops.
Yeah. Also, if you liked this time, because we're experimenting with other time slots, if you liked this time slot, please include that in your survey because it helps us to know when to schedule things. And also, yeah, if you have any other questions, you can ask Alane directly, pass them on to me. I can pass them on to her, whatever you feel. But thank you so much, Dr. O'Connor, for this presentation. Thank you. I'll give everybody 3 more minutes back in their hour. Thank you so much to everyone for joining us today.